Good afternoon, everyone. Welcome to the KPQC Learning Forum for August. Please make sure you enter your name and agency in the chat so we can keep track of how many people have attended from each facility. And I'll turn it over.
Hi, guys. Forgive me for my dress down attire. We were running on Baby Central in August, like many of you are. And so I got a shower, and we'll just call that good enough for today. As we always tell you, please, and look at you all. You are so on top of it. Name and agency in the chat. We do keep track of who comes to see us. We also look back sometimes to see name associations to hospitals, and that helps us put some ideas together for who to contact. So thank you for that. Next slide. The most exciting next thing beyond our learning forums and our direct work with you all throughout the state is our conferences that we do typically in the spring and in the fall. And as in years past, we try really hard to do a virtual conference once a year so that we can hit more folks throughout the state. So this fall's conference on October 22nd from 9 to noon is virtual only. Nobody will be in person. We're all virtual that day, including our speakers. Okay. So we really want everyone to register. I have the link at the top, although I'll have Tiffany type that into the chat right now with a direct link. There's also a QR code. You all will get this too in your follow-up today. Hopefully you've gotten it on through the listserv in multiple occasions as well. But we are excited for our two keynote speakers. As part of the survey results from our hospital across Kansas, including those enrolled in for a trimester and those that are not currently, there was a lot of feedback about sepsis in the obstetric world. And so we called one of our colleagues and said, hey, how about you talk specifically about sepsis in the obstetric continuum? And Dr. Angela Martin from KU, in fact, will spend a good portion of the morning talking about that. And the second is Emerson Frazier. Many of you know Emerson from past presentations or her work in we'll say the world of implicit bias and birth equity, but Emerson has taken that to the state and national level now. She is by definition the director of health equity and policy at Stormont, but I will tell you she knows a lot about what's going on at the protocol level, the lawmaker level, and on and on. So excited to hear how we use data to really make a difference at the bedside in 2024. So you've heard these conversations for years, but Emerson's going to bring to light what the latest is that we can do to help women birth safely within the scope of partnerships and collaboration around racial demographics and data that helps us do that better. So register. We're excited to get more information out in the month and so ahead. But one of the other teasers we have is that we will be unveiling the next bundle that day. So on October 22nd, the last thing of the day, we will unveil, let all of you know who want to participate. And we hope that's all of you plus some in our next safety bundle. We'll think you'll be excited about what we're going to tell you. It's a good one. And so we'll include that in our day. Next slide. So we like to hit some high level important shareables each month, and this is no exception. So there's going to be a couple of things to get through. Again, you'll get all of these in reference from Tiffany after today's learning forum, but you'll also get specific links and further information that you can look through, including the slides afterwards. So let's hit those up, Tiffany. First thing, there's one more session put out by the National AIM ACOG group, talking about how individual hospitals can do case review regarding maternal morbidity, so severe maternal morbidity cases. And this is great content. If your hospital is doing some type of chart evaluation as part of your debrief or as part of your QI process, we applaud you. That's an important next step through our country. But AIM has done one better and said, we can train you on how to use this specific template so that your hospital can use its own process, but use a standardized evaluation tool. So the last session is coming up. I think it's within the next week or this week, and you can register still. I just checked that this morning. So there's that. Next slide. The next few slides are about reports that are coming out. And typically we hit these things at the start of the year, perhaps in the summer. Some of it's a little bit delayed, but KDHE is doing a great job of getting up as updated as we can with identifying and reporting out data. The latest report, and this is one of them, the KDHE Vital Statistics Report, it's the natality report specifically from the 2022 data, had some really interesting pieces. So the full link to the document is at the very bottom there. Again, Tiffany will share this out when we get done. It'll also be on your slide deck. But pay attention to, unfortunately, what we're seeing and what this data means to us. So when it talks about birth outcome data, this report kind of starts to begin to dive deeper into what we're finding, again, from 2022, 2 years past when COVID came to be. Not all about COVID, but important to keep in mind the timeline. And it mentions that Black non-Hispanic mothers had a specific amount of births in the subset of what they worked through, and showed 25% experienced poor outcomes of that group. It dives deeper into what those poor outcomes were, low birth weight again being one of the top concerns. It talks about prenatal care access in this document, and we find that women of color are also not achieving prenatal care at the same levels in Kansas, and that lower prenatal care has equaled worse outcomes. Again, no surprise there, but we know that access continues to be a problem. And it also shows that we need to pay attention about the racial demographics of our lowest outcomes patients. On the right-hand side, it's one of the deeper dives into what the medical risk factors are of white, Black, and Hispanic birthing persons in 2022. And those diagnoses, we'll call it, on the left-hand side of that graph that has gray, orange, and blue on it, talk about those are the most frequently identified poor outcomes or complications of pregnancy, to include vaginal bleeding, eclampsia, preeclampsia, gestational diabetes. And you can see, and that's why that arrow is sitting there, that there are many poor outcomes, more worse outcomes for women of color, specifically our Black non-Hispanic state residents. And so we need to pay attention there. I will also tell you that this document was very clear that we continue to see a tremendous increase in poor outcomes across the board. So let's also not be naive to think that this is only about race, though it's extraordinarily important to talk about race in that moment. It's also a moment to talk about that we're taking care of higher risk patients. Again, not a surprise, but unfortunately, these data sets, including alcohol use, smoking, vaping, preeclampsia, gestational diabetes, the numbers are significantly increased from the previous report. Next slide, please. This slide and the next slide really talk about, again, you can see the population group listed at the top and those abnormal or poor outcomes to the left. I wanted you to see, and again, if you get a chance, read that document. It's not a long one, and it'll talk about the hypertensive disorders really escalating along with diabetes. We think there's an association to obesity in our state, but not always. And so, again, I'm drawing your attention to some of the things that tell us where to really lead in the next process improvement plan, hypothetically. Next slide. The slide before and this slide specifically talk about honing in on the regions of our state where adverse outcomes are the worst. So if we talk about certain sections of the state that have higher population of poor birth outcomes, that's what this slide is about. So poor birth outcomes, and then population group of those poor outcome percentages all grouped together, and then the section or the region of the state where those are occurring. It may look like a busy slide, but what it screamed to me is there are pockets of our state that have higher poor outcomes than others, and not all sections have equal poor outcomes. So even within that region, there are higher levels of, for example, diabetes here, but preeclampsia here, and preterm birth and low birth weight here. So what you want to do is find your region or do a dissection into all of them. And then Tiffany, if you can go to the next slide. These are the regions that are referenced in that previous slide. Okay, so again, how far you want to dive and to see what's going on in your, maybe even your region, but certainly in your county, and then follow that through to the state. Those two slides are connected. Again, there's a great link into the full document there at the bottom. Next slide. Again, while we're on the conversation of how are we doing in the state and looking back over the last few years to say, hey, our poor outcomes getting worse and we should throw up our hands and say we're on this HRSA-based site to be extraordinarily helpful and quite frankly gave me some hope. So if you, it's a specific map. Am I still on? Can you guys still hear me? Okay. Okay. Sorry. My internet cut out. Maternal and child data by, and you can dive as deep as you want to from city, county, state, region of the United States, you can grab as far out as you want to go. But HRSA put a lot of data together so that you could type in your county, drill down to breastfeeding rates and see where your county or your state, et cetera, sits from the HRSA information. And again, the mapping of, and you can see to the left hand side of the slide, the things that are specifically targeted. I found smoking during pregnancy to be the most interesting. I think that smoking is unreported now because of vaping, and that the birth certificates do not talk about vaping. They talk about smoking and packs per day, which 5-10 years ago, that might have been the way we mapped it, but that's not how we're mapping it. So I was watching that piece. But find your site. There are some good news stories in there, and the high breastfeeding rates across the state are one of them, lower cesarean birth rates and others. Like, this could be a way for you to show off to your folks at your hospital or in your county how well you're doing. And I saw many of you on there. Next slide. And then to not feel better about ourselves, but to know we're not alone in our fight to improve outcomes. CDC found, and this came out on national news, you may have seen other articles like this one from NBC News, that we knew that oftentimes more pregnant women are not seeking prenatal care early or continually or repetitively in pregnancy as we had hoped. And that sure enough, in between 22 and 23, we saw a reportable difference in the percentage of women who are achieving prenatal care. In the state of Kansas, what I mentioned several slides ago when we talk about poor birth outcomes, the numbers are pretty clear about adequate prenatal care, inadequate prenatal care, drill down on population groups, et cetera. But it is absolutely true that in terms of standard OB care, right, meaning midwifery care, family practice care, OBGYN care, et cetera, that is not, we are definitely seeing a decrease in access to prenatal care. And that has to be said to everyone at the bedside of inpatient care, to home birth, to ER departments that catch babies by accident. We all need to pay attention to what's happening there, because we know that that prenatal care, adequate prenatal care, can improve outcomes. So we're not alone. Now we got to fix the problem. Next slide. And then the last part of just my quick update on data throughout Kansas. This comes from the 23. So if you look at the top left graph, birth rates of Kansas residents from 2004 to 2023. I just want you to pay attention to the fact that the birth rates are continuing to decline. And we certainly, you can pull that out from your county. Our county had a 7% decrease in the last year, actually, of our birth numbers, and that's significant. And furthermore, it talks about the percentage of births in the 1, 2, 3, 4, 5, 6, 7 counties in Kansas that make up the highest birth numbers. So in other words, in those 7 counties, Douglas, Gary, Johnson, Leavenworth, Sedgwick, Shawnee, and Wyandotte, we make up 59% of the births in our state in 2023. And you can read further that many of us had a significant decline in our birth rates. What does that mean? And why is that happening? Is it bad? Is it good? Right? Just pay attention that we're seeing lower birth numbers across the state. And then the deep dive into the right-hand side talked about smoking and pregnancy for live births in Kansas, premature birth before 37 completed weeks, et cetera, low birth weight. So you're seeing the same data come out in different sources with more and more updated information. And that, again, we use this data to figure out how to help women and how to help families and how to help babies. But it's not all gloom and doom. It just is a matter of how we can help and how we can improve outcomes at the bedside every day. Next slide, please. A quick couple of teaser items. Next month will be vaccination.com education. We know it's vaccine season because it is flu, RSV, COVID season, certainly upon us, but I wanted to make sure you had some great resources in your hand early. So couple of websites here. The pregnancy highlight card is not new. You see that pictured front and back and excuse me, front and back in front of you. This is a great reference and resource for you to hand out to patients or to reference online. And it talks about the 4 primary vaccinations during pregnancy, but we use it in the postpartum setting as well. So some of our patients that have declined or waited till postpartum, or in that season where they didn't vaccinate because they delivered and then they want to vaccinate postpartum, X, Y, and Z algorithms are played out, but this information is great for patients with further information on the QR code on that brochure. You can get this highlight card. That link is there. Furthermore, the key resources page. I would really encourage all of you at hospitals, outpatient clinics, not KPQCs, FQHCs, and health departments, go on that website. What wonderful documents to make explaining vaccines and pregnancy, the safety, the efficacy, when they're given. Really great information for providers, for bedside folks, for triage, but also for the patient. All free. Print as many as you want and go from there. But great information for you to have as we head into this very heavy season of explaining vaccines to women. Next slide. This is a lot of language about something that's very important and a major change coming into our state. This will be one of the highlighted topics for next month's learning forum. But again, it's happening right now, so we wanted to make sure you knew about it. It's highlighted there, but what you should know is that the CDC is sunsetting the hepatitis B birth dose program through the VCF program in our state. And what that means is that essentially we will start to have to figure out Medicaid-based patients, right? And those that are covered and those that are private pay getting hepatitis B vaccine at the bedside immediately after delivery, meaning during admission. For me to explain that to you is not fair. You need to talk directly to the people who are in charge of this. And many of you have already reached out to that regarding that program and the change of the hepatitis B birth dose, not after discharge or on a vaccine schedule, but at the time of birth. That is changing dramatically. And the people that are the most knowledgeable include Rachel Sample, who is the vaccine operations manager at KDHE. Her email is there. She wants to hear from you if you haven't already touched base with her about the changes at your hospital level, and she will be able to answer questions. We will also follow up on this next month and make sure that if there's questions, we can lead you to the right person and perhaps hear some good news stories about how you're transitioning from everybody being covered, all infants being covered at delivery, to figuring out how we get everybody a dose, but from the right program, essentially. Next slide. Next slide. Then one more thing before I hand it over to our guest speaker today. She's no guest. She's been a part of our team for a long time, but excited to hear from her. One more reminder to everybody, we are done with QHI. Why we continue to use that to evaluate data that you've put in. All data needs to come directly to Carrie and I, please, via email. If you have a question about that, just reach out to us. But once you've completed a project or a benchmark in for a trimester, simply email Carrie and I, give us an update. If we have a question about that, we'll reach back out. But please do not put anything more in QHI. Next slide. Finally, we get to Jennifer. So you all have seen Jennifer through the years since we've been starting the maternal mental health portion of the 4th trimester initiative. When we talk about poor outcomes for our infants and our moms in Kansas, we know that maternal mental health is not one of those identified because it's not asked about on birth certificates or death certificates. But we know the drill down includes many poor outcomes based on maternal mental health outcomes. And so we asked Jennifer to come back today to touch base with all of our sites and perhaps even stretch her arms a little further across Kansas for those that need help connecting patients to maternal mental health. Our postpartum model that we use for 4th trimester clearly mentions that these are key pieces of follow through and best practice model for postpartum care in our state. Next slide. So without further ado, I'm going to introduce Jennifer. Jennifer, certainly jump forward to your slides, but yeah, you can skip that very busy one. But at the same time, don't hesitate to reach out to Jennifer. We'll have a question and answer session at the end, but also to in follow up. Jennifer, welcome. Thanks for being here.
Thanks, Tara. You can go to the next slide. Thank you. So I am with Kansas Connecting Communities. Many of you, I think, should be familiar with that name. I'm familiar with most of the names on this call, some new, but I'm looking forward to meeting you all in good time. So as Tara mentioned, I've been with the team for since 2021, which I think is pretty much about the lifespan of the FTI work around maternal mental health. And I'm going to talk today about kind of the progress that we've made and then where we need to go next very practically. Next slide, please. This is required on all of our presentations. We are a HRSA funded program, so we have to do that little funding statement. And then on the side, I want you to notice all of our partnerships because this lets you know that we are connected and we can help you all get connected. We have partnerships and medical systems, in research institutions, with Postpartum Support International, with CKF addiction treatment centers, and the list goes on and on. These are major partners, right? So please, please, please remember that we can help you all get connected. We have networks across the state and then some. Next slide, please. This is how you get in touch with us. We offer training resources and technical assistance, which we will talk about today. We also offer a consultation and care coordination support line. This is provider facing. We are not here to take over the care of your patients. We're here to help you figure out that what next piece and to talk you through resources that are available, help you with some of that care coordination support. It is staffed by a social worker, so that's who you'll get when you call the line. And then if you are a prescriber and you are trying to figure out the what's next for treatment planning with any perinatal patient, you can get a one-on-one consultation with the peripartum psychiatrist or our OBGYN on staff who has her certification in perinatal mental health. They can talk you through diagnostic stuff, treatment planning, medication and dosage questions. They're a really great resource, so please use that. Next slide, please. This is something that's kind of new and not really new. We have integrated with our sister program, which serves pediatric populations, so 0 to 21 years of age. Same model, same services, training, education, access to resources, consultation with adolescent psychiatrists, child and adolescent psychologists on their consultation line team as well. So if you have a family and maybe you are seeing mama for labor and delivery and you know that she has a kiddo at home who could use some behavioral health support, you can absolutely link that into your recommendations for pediatrician, family medicine, anyone who is doing follow-up care for that family. This number will get you both programs. So you press 1 for pregnant and postpartum folks, and you press 2 if it's about a pediatric patient, and then you have access to both programs. Next slide, please. All right, so talking through what we have done with the FTI cohort in the last few years and what our role in all of this is. We primarily offer training and one-on-one technical assistance for all FTI facilities and centers, and we tailor that to your specific needs for maternal mental health. So the overall benchmarks include having a universal screening happen for behavioral health conditions before postpartum discharge with a validated tool. So this includes screening for depression, anxiety, and substance use. For all of you who are just like, we have some questions in our intake or assessment, but I'm not sure if they're a validated tool, that's a great reason to have a quick talk with us and we can help you find out if that constitutes a validated tool or not, and what the next steps there are. We also support you with developing basic referral pathways, including loop closure. So having that follow-up conversation with either the patient, whoever is taking over postpartum care, or both. And we can even help you build out a resource list for your local area. And then we also support you with updating any kind of policies, putting training in place for your staff, either as they onboard or just getting your current staff up trained and ready to support maternal mental health and their day-to-day. And then we can also support you in thinking through how to set up your data so that you can actually assess whether you're meeting these benchmarks or not. Next slide, please. So to date, Of all of the facilities and centers in the current cohort, 71% have submitted baseline data. Great job. 56% of you have worked with us one-on-one in some kind of TA, so quality improvement or screening implementation. Just under 70% of you have depression screening in place, a few less have anxiety screening in place, and then about 15% of you have substance use screening in place. The reason why these stats are important are because we know, as Tara mentioned, that mental and behavioral health are foundational to improving outcomes in pretty much every other area. Not only does it increase adherence to prenatal care and following up with postpartum visits, it also is better for bonding for mom and baby. It's better for breastfeeding. It's better for adhering to healthy changes that we want mom and baby to have during pregnancy and postpartum. It's also really important to note that there are direct links between substance use and poor prenatal care. Most of the time, that's not really based on something that we within our institutions can really change, but it's really more about shifting the mindset and letting folks know that it's safe to engage in prenatal care even if you're using substances. We have a lot of training on that topic specifically, perinatal substance use. They're fantastic. I think it's an area that's kind of scarier when you're doing bedside care because it's maybe a little bit more of a gray area how you would address and follow up with that. Issues of mandated reporting are always a concern, both for your patients and for you in some cases. So we have a lot of training around that. I'd encourage you to reach out to us if you are interested in learning more about that, because I think there's a lot that we can do in terms of just having these conversations in a harm reduction kind of way that would really help folks feel more comfortable engaging in prenatal care if they're using substances, right? We need kind of that wider mindset shift, kind of statewide and nationwide, to be honest. Next slide, please. All right, so from 2021 to 2023, we had about 9 FTI sites who submitted quarterly screening and referral data to us. These are sites that we did a lot of intensive one-on-one technical assistance and helped them get policies in place and screening in place. And honestly, they are doing fantastic, especially in comparison to some of our statewide data on screening and referrals. So almost 90% of them are screening for both depression and anxiety. About 80% of them are screening consistently for substance use. That's all using a validated tool. And then about 8.4% of total patients who were screened had a positive screen. That has increased a bit since we've done some TA with them. And we don't think it's because the prevalence has really gone up. We think people with some of the training and quality improvement pieces that we've been able to work through with those sites, we really think that that's more people are feeling more comfortable with honestly reporting to the screens. So just want to point out that 8.4% is still probably a little bit under what we expect is actually happening in terms of perinatal behavioral health conditions statewide. But that's about where we're at in terms of data. I want to point out the 92.8% of positive patients referred. So this is fantastic. This is not something that is seen in even other cohorts that we work with. The FTI sites are doing a great job of that postpartum discharge workflow of getting folks actually connected to treatment if they have a positive screen for behavioral health conditions. I know that this is not easy. It is definitely not easy even to have all the logistics in place, but then to have all of your staff skillful and confident in having that conversation and helping that conversation along in a way that the patient is ready to accept a referral. This is fantastic. I am so proud of the FTI sites for this. And then again, just to give a little bit of context on this data, these sites had an average of around 1,800 patients per quarter that they submitted data. Next slide, please. All right, so Tara asked that I go over some common challenges, and this is great because all of you need to know that you're not alone in the struggles that you face for maternal mental health. These are not just for FTI sites, they are across the board. You are not the only ones in the maze looking for the cheese. So time is very valuable and so short in supply, especially in labor and delivery settings. You all have like 2 days to get everything done. And that is a lot to pack into a short amount of time. We understand that that's a huge challenge. Comfort and efficacy in addressing maternal mental health and substance use. This is hard stuff to talk about, even for folks who are well-trained and professionals and do it all the time. Even in the realm of mental health treatment professionals, this is hard to talk about during pregnancy. It's a really hard subject to engage in, and it's difficult, right? So that is a challenge that pretty much everyone faces, even if you're well-trained, even if you've been doing this for a while. Also want to recognize that getting stuff in place requires buy-in from leadership and your admin for a variety of reasons, not just funding, but making sure that it's compliant with all of the other policy pieces that you all need. So that's a really common challenge that we see. And then few options for referral. Everyone always needs more resources, and sometimes those resources are really hard to find, or maybe they haven't been as helpful when you've utilized those referral resources in the past, right? So there needs to be some intentional relationship building or additional resource options. So that piece can be a really big challenge. And then loop closure is huge because you discharge them and then they go where? Maybe a lot of places, maybe one place. Maybe it's really hard to get that loop closure and find a spot where you can connect with the patient or the whoever's taking over postpartum care and really see whether that referral was effective, whether mom's doing okay. That can be a pretty common challenge. Next slide, please. All right, so these are some solutions. The first and most important thing to do is just start somewhere. Easier said than done. That's why we're here. We will help you take that first step. But some solutions that we've found that work really well in this setting and for these sites are really tackling the most attainable piece first. So starting where you're at, setting reasonable goals. It is not reasonable for you all to get policies updated that support comprehensive screening for both depression, anxiety, and substance use in like 3 months. It just doesn't happen. It just takes longer than that. So make sure that those goals are realistic and that you can chunk them out in a way that you're not going to get overwhelmed. Building and piloting a workflow is really effective because then you can also kind of use that to advocate for change if you need some buy-in, right? You can say, like, we've been trying to screen everybody and we know that this percentage of our patients are screening positive, so we feel like we really need to address this more as a facility or as a center. And then doing what makes sense and is sustainable for your team. We can talk all day about recommended screening tools and best practices, right? And we want you to follow them. And then also, there are a lot of different ways to stay within those best practices. You don't have to use the gold standard screening tool if you have ones already built into your ER that are perfectly well validated for this population. So finding little things here and there where you can really just do what makes sense and is sustainable for your team and your center and facility. Aiming to train all staff on the basics is really important, right? But you also have to kind of shift the mindset and engage in a lot of practice. Prioritizing the quality of screening interactions is really needed, right? Like just having a screening tool in place doesn't mean that your staff are all comfortable asking about substance use in pregnancy or at delivery. That's a really hard conversation, pretty touchy, right? So it takes a lot of practice. And especially if you are going to be able to reliably say that folks are answering honestly, that takes a lot of very quick rapport building and building an environment of safety and trust for that patient. It's really hard to do. So the more that you practice that, the easier that is. Next slide, please. Buy-in. Okay, so I'm going to say this and then I'm going to give it some caveats. Preventing maternal deaths should be enough to get buy-in from everyone that you need to get buy-in from, right? We know that as a group, suicide, overdose, unintentional poisoning, and there's one more. Jill might know this because it's from the MMRC data, so feel free to add that in the chat. that group of behavioral health conditions or considerations is the leading cause of maternal deaths in Kansas. So associated with pregnancy, I believe. Jill, feel free to correct me in the chat. What we know is that this piece, this behavioral health piece, is key to reducing maternal deaths in the state of Kansas during the postpartum period. We really can't address those things unless we're getting buy-in to screen, to identify, to connect to treatment, right? So just preventing maternal deaths should be enough. And we also know that sometimes it's just not, because there are other priorities happening. We have to find and demonstrate other benefits. So payment incentives for screening and referrals through designations from commercial insurance carriers like Blue Cross Blue Shield, I think, has a maternity care designation that is an incentive for screening and referring for mental health. Medicaid reimburses screenings. So there are ways to demonstrate financial incentives as well for getting some of these things in place. Planning for the what now can actually help you with buy-in as well as helping with staff comfort, right? Like nobody wants to screen and then send someone on a bridge to nowhere. So having that what now piece in place is really helpful for just screening as well as for getting buy-in. So including really clear next steps in the policy and the workflow for what will happen after a screen at a certain score, having universal education like printouts that are patient facing, like on hand, that you can just include in their discharge packet and go over with them is really helpful. And then having a plan for documenting tracking, and especially with loop closure, super helpful. So for having few options, I mentioned this is a struggle for pretty much everyone. Sometimes you have to think outside the box a little bit and think about community and medical resources that are not just therapy and substance use treatment options, like in the traditional sense. So for an example, we know that peer support is incredibly effective at supporting positive mental health experiences for moms in pregnancy and postpartum, right? We also know that peer support, even if it's not available in person at the local level, there are some fantastic peer support groups through Postpartum Support International that are virtual for a lot of different situations. So they have one for military moms, they have one for veterans, they have one for parents who are in recovery from substance use disorders. They have a lot of really fantastic peer support groups that are available really if you have any access to internet. So thinking outside the box and maybe thinking a little bit outside your community, or even thinking about support within your community. Are there moms groups that you can refer them to just for some social interaction in that postpartum time period, that you can just tell them, hey, this is a moms group that I heard is great. And sometimes it's helpful just to be around folks who are going through the same thing that you're going through and know that you're not alone. Also, sometimes you are the resource, and I know that everyone is tired. I am no longer in direct service because I got really tired and I got burnt out and I needed to do something different for a while. And that's okay. If you're in that space, please take care of yourself. It's not always going to be on your shoulders. It shouldn't always be on your shoulders. But sometimes, if you have the capacity, if you're in a space where you can do it, you can be the resource. Encourage your colleagues or others to pursue additional training. You all can start your own peer support group in the community. We have an entire guidebook and can help you walk through how that process needs to happen. You can access additional training on maternal mental health. You can even get support for scholarship support through our program for certification in perinatal mental health, so that sometimes you can be the resource, right? It's not always the case, but if you are interested and you are in a space to do that, please do so, because the best resources in a community come from the community, right? It's always more effective if we're building those from the ground up at the community level, instead of trying to develop resources outside the community and then just send them in, right? Loop closure, again, this is easier said than done, but you can look for You can look for opportunities to build that relationship between your inpatient and outpatient settings. You can map out what the referral workflow looks like. I highly suggest paying really close attention to common communication that you want to be in place in order to make that referral from prenatal to delivery to postpartum a lot smoother. You can also look for some additional touch points like a nurse or social worker follow-up call, a newborn hearing screening, lactation support, and that doesn't have to be another formal screen. It can be, but that can be as simple as, hey, I noticed that you screened this on your EPDS. Do you think it's better? It's worse? How are you doing? How are you feeling? It doesn't have to be super intense or time consuming. It can just be that quick check-in to see if they are feeling better or worse or followed up with a referral. So look for those little time points. Next slide, please. All right, this is the call to action for you all today. So we have connected with, I mentioned earlier, quite a few of the FTI sites. And we have a goal to connect with the rest of you before the end of October, because that's when we really need to have this this formal step wrapped up for the FTI things. So this QR code will take you to a calendar that has multiple time slots, multiple dates from now through the end of October already in place. I'm going to pop a list in the chat. This is not calling any of you out. This is absolutely just so you know who you are if you need to connect with us. So these are priority sites for signing up for, it's not going to let me copy and paste. Hold on just a second. I promise I actually did practice this. Let me get it. This is not calling any of you out. This is just saying, hey, we either haven't had a one-on-one with you, like maybe some of you have submitted your baseline data and just need to connect to wrap things up. Maybe this is something that we haven't heard from you in a while. Please, 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 if you are on this priority list, snap that QR code and sign up for a spot to do a 30-minute Zoom call with our team. It's super low stakes. We literally just figure out what you're doing now for maternal mental health, and we will help you figure out if there are any next steps that you need to take to meet those FTI benchmarks. And we can help you actually achieve those benchmarks, right? So we can help you figure out which screening tool to use. We can help you build a workflow. We can help you get a resource list together. We can help you review your policies. You do not have to do this piece alone. We know it's a lot. Please let us help. If your staff needs training, our team can provide that training for free. We can direct you to advanced training through scholarship applications, etc. So pretty please go ahead and sign up. We'll also ensure that the link is sent out in the follow-up email for this. So if you didn't have an opportunity to sign up today, please, please, please sign up. We may also send you directly from the KCC email a reminder to sign up if we see that you haven't done so. Again, this should not be a scary meeting. The goal is for us to help collect that data that Tara and Carrie and Jill need to sign you off on the maternal mental health piece so that you all don't have to be responsible in submitting a ton of extra stuff. And it's helpful for you all just to have that checkbox to make sure that you know that you're meeting the benchmarks. All right, next slide, please. This is a QR code that you can use to download a contact card for the consultation line. If you have a question about any of this, if you want to schedule a training for your staff, if you would like to get a case consultation on a current patient, this is where you go. This is not a crisis line, but it is staffed by our consultation team, including the social worker, Monday through Friday, 8 to 5. Will return your call or form the next business day. If it is a crisis line, please use your crisis resources. Next slide, please. This is a sign up. This sign up form just kind of streamlines your access to that consultation line. You just have to enter kind of like your name, your org, what zip code you're located in, kind of what counties do you see patients in. That just helps us with our grant reporting. If you don't access this sign up form here, then when you call the consultation line, Caitlin will just ask you a few of those questions just so that we have that on record. Again, we don't report any of that information out individually. It's just aggregated and it's used for our reporting so that we can continue to fund the training and services that we provide. Next slide, please. And then I mentioned this earlier, but we have scholarships to support advanced trainings in perinatal behavioral health. There is in conjunction with Postpartum Support International Kansas chapter, we have developed a list of vetted trainings that are really high quality. The list is linked there, and then you fill out an application. I don't think that we've ever refused an application, so you're pretty much surely gonna get it. And then you just take it. You take the training, we reimburse you, or we can provide cost upfront before you even register for some of the trainings. So if you're interested and have the time to do this, we highly encourage this. We want a really highly trained workforce in Kansas because we know that that really leads to better outcomes for patients. Next slide, please. All right. Any questions? And if I missed something in the chat, please feel free to come off mute or respond, push it up higher in the chat. Also, Jill, thank you for adding that data into the chat. Right. If there are no questions, I think that is that's a wrap up for me. Thank
Jennifer,
you all.
actually, you did a phenomenal job. And what I mean is I think that as we talk about poor outcomes, when you unbox the reason why, right? When you unbox the real baseline, I think you just foundation, all words are correct, but when you figure out what's going on, 9 times out of 10, there's a maternal mental health concern or develops after, right? So I'm thinking about preeclamptics or eclamptics that have very traumatic birth experiences and then need postpartum services, let alone those that need it in the antepartum setting. So this is an unboxing of how we can help. I also think that many of you have described to me feeling overwhelmed by what Jennifer described to be, let's just start somewhere and see what we can do to improve the warm handoff to patients in the immediate postpartum labor and delivery setting. And I know that you can make that work actually fairly easily. It's the follow-up outside of your facility that I think we struggle with too. So you're not responsible for everybody, but we'd love to have you make sure those of you that are not where you want to be, Jennifer is your resource, and we believe we can make a difference. Remember, post-birth, our number 1 4th trimester goal includes maternal mental health as a red flag. So when we're training and teaching and educating across the state about the red lights, green lights, or sorry, let me say that differently. Green lights, yellow lights, red lights, in terms of if you hear a family member or friend or colleague, or you see it in a patient and how they should achieve care, how quickly, maternal mental health is a red flag. So please know that they're going to be calling us if we educated them well, and what do we do with that in that moment. Thank you so much, Jennifer. I appreciate your time. The follow-up to this, I just wanted to gently remind everybody again, make sure you register for our virtual conference. Excited to see you all in October. Of course, we will have, next slide, Learning Forum in September 24th. Lots and lots of information about pediatric vaccines specifically. Also, we'll revisit the maternal vaccine story and hammer both in terms of best practice models, what's available in the state, what the recommendations are, and fuel and welcome some questions and concerns regarding educating at the bedside. I think that's all we have for today. So you guys, thank you so much. Take care, and we'll see you next month.